right, you guys. So we're going to start a new unit here. This is going to be a deep dive into more of the complex disorders like tuberculosis and lung cancer and the sleep disorders and a few others. But I wanted to start here with tuberculosis because this is something that it can take a little bit to kind of understand, but I hope we're going to be able to break this down into all of the different categories, all the different general information, the risk factors that are associated with it, and what we can do treatment-wise and why it's so important to treat these patients effectively because it is such a highly contagious disease. So we're going to jump right into it, all right? So first things first, when we talk about tuberculosis, what we're doing is we're talking about a highly contagious chronic bacterial infection. So this is something that is going to be transmittable and highly transmittable from patient to patient or person to person. This is going to be kind of one of those things where these folks could be patients in the future and they are general people out in the regular population from day to day. The thing with TB is it will start in the lungs, but it doesn't necessarily mean that that's where it's going to stay. It can move from the lungs and impact the brain, the spine, and so many other areas, even bones, it can impact when we talk about TB. When we talk about TB, this is one of the world's oldest diseases. It's one of the oldest diseases and it's one of the most widespread across the world. So this is one that's not isolated by generation, by time, nor is it isolated by landmass or area. So TB is everywhere. It's been in our history books, and we're going to talk about some folks that have had TB who you may be familiar with. So when we talk about categorizing TB, what we're talking about is labeling TB based on the period or the phase or the status of the TB at that time. So the four different phases that we have: primary, latent, reactivation, and disseminated. And we'll get into those here in just a minute. But before we jump into that, let's talk about some of the risk factors. So when we talk about risk factors that are associated with TB, those that have a weak immune system, whether that's TB, whether that's chemotherapy patients, whether that's patients that are on immunosuppressants that have had an organ transplant, lots and lots of different reasons and rationales why the immune system may be weak. People that live in small rooms, especially those that don't have sunlight, nor does it have fresh air, there is an increased risk of getting TB simply due to the lack of circulation of air when you are exposed to somebody that has TB. Patients or people that are elderly, those that live or work with people who have TB, the homeless, residents where TB is prevalent in the group settings like jails or homeless shelters, nursing homes. Those are all hotspots for TB to run wild. Folks that have struggles with alcohol abuse or IV drug use, they are more at risk for tuberculosis as well. And then us as healthcare providers, we are at risk because we never know who's walking through our doors and what they have. And that really doesn't matter. We just still going to treat them the way that we need to treat them, but we just never know. And the patients may not know. They just know that they're sick and they need to be treated. So we can't kind of shield ourselves, or when we get the opportunity, we need to shield ourselves as best as we possibly can. When we look at the pathophysiologic changes, you're going to have alveolar consolidation. This happens because the AC membrane is starting to get destroyed. You end up with the pulmonary capillaries that start to get a little bit dilated. When they're dilated, they lose their selective permeability. From that, you get fluid leaking and a destruction of the AC membrane. You're going to hear me talk about these things, these tubercles and these granulomas that are going to be a hot topic. They're going to be a very frequent word that I use often. And what these are little like nutshell casings that engulf the bacteria. From those tubercles or those granulomas or even lesions, that's another word that can be used there, they can create a cavity that occupies space where the lung parenchyma should be. You can end up with fibrosis, secondary calcifications in the parenchyma as well, and that leads to chronic lung issues when you start moving into that pulmonary fibrosis. And then you can get distortion and dilation of the bronchi, very similar to bronchiectasis, and you're going to have a number of bronchial secretions as well. So this is one of those characters that I was telling you guys about. This is a character from the movie Tombstone. This is Doc Holliday. It is played by Val Kilmer. He's a very famous gunslinger, and this guy is full of comedy and puns in this movie, but he has TB, and you get to see him from perhaps latent stages TB to the end stages of TB, and you get to kind of see him do all the things that you're not supposed to do so that you can survive tuberculosis. So he does everything you're not supposed to do. But still, it's a great movie. Old Western. If you can handle the gunslinging and the cussing, it's a great, great movie. But anyways, talking about primary TB, this is the primary infection when you are first exposed to that pathogen. So, and that pathogen is what we call Mycobacterium tuberculosis. Mycobacterium tuberculosis, or some people just call it M. tuberculosis. And when we look at this bacteria, it is a rod-shaped bacterium that is a bacilli. It's a rod-shaped bacilli, and this must be inhaled. Whenever it's inhaled, that bacteria will embed itself into the alveoli, and what ends up happening is over the next 3 to 4 weeks, that alveoli start to proliferate. They start to multiply, and you start to get this infection that is very overwhelming. It's very, very similar to pneumonia. So you get the inflammatory response very similar to pneumonia, where you have an influx of white blood cells or leukocytes and macrophages to that affected area. But unlike pneumonia, with TB, they do not kill, the white blood cells do not kill the bacteria. What they do is they engulf and they encapsulate that bacteria in those tubercles or the granulomas or the lesions. So they end up engulfing that bacteria. From that engulfment, it causes those pulmonary capillaries to dilate. When those pulmonary capillaries dilate, that selective permeability goes away, and you get this leaking of pulmonary fluid. You get the leaking of pulmonary capillary fluid into the interstitium. From the interstitium, it'll start to affect the alveolar epithelium, and that starts to swell. Once you get that fluid that breaches the epithelium and moves into the alveoli itself, the alveoli become consolidated and filled with fluid. And at this point, with a patient that has primary TB, they will have a positive PPD, or a positive purified protein derivative. And that is the skin test that we do every year, or what you will learn in this course, what is called a Mannau test, And from the PPD, you'll see that it is positive, but what is happening internally is your body is trying to encapsulate. It's trying to encapsulate that bacteria with those tubercles or granulomas. Once it does encapsulate or trap that TB bacilli, it will create this spherical or nut-like structure. So if you were to think about pecans, if you've ever cracked open a pecan, it has this hard circular surface on the outside, oval-shaped surface on the outside, and inside is the actual nut, and that's the meat of the nut. And what I'm talking about is these tubercles or these granulomas are the actual shell, and the TB bacilli are the meat or the nut inside the shell. So that's kind of what happens when it comes to the pathophysiology and what's taking place during primary TB. Some of the things that you will see when you look at a chest x-ray is you'll be able to see those granulomas. You'll be able to see those tubercles, and what those are called, or what you end up seeing, are small but sharply defined opacities. So you'll be able to see kind of this rigid outline of that opacity. And they can be difficult to detect because they can hide behind ribs or they can hide behind the cardiac silhouette. But when you see these in the chest x-ray, they are what's called a Ghon nodule. Ghon nodule, G-H-O-N nodule. And those are those tubercles or those granulomas. Then you can have those Ghon nodules that start to impact so much of the lungs that they can start to navigate their way into the lymphatic system. When you get Ghon nodules that have lymphatic system involvement, you end up having a Ghon complex. So Ghon nodules move to Ghon complex whenever you involve the lymphatic system. Again, those tubercles or those granulomas or those lesions, these can be seen on that chest x-ray. These are what encapsulate that TB bacilli to capture it right where it's at, so that it does not, so it can contain that bacteria and it does not navigate to other areas of the body. These tubercles and these granulomas, they typically form within 2 to 10 weeks, and like I said, they are designed to prevent any further spread of that TB bacilli. Once the body has the TB under control, it can lead to what we call latent TB or dormant TB. So when we have these granulomas and these tubercles that are forming, this is the action of seeing the body working to encapsulate the TB bacterium. This is an image of the tubercle. If you look on the outside here, this is that hard nutshell casing, and inside here would be the TB bacilli. So you've got your bacteria on the inside and the hard shell on the outside. Moving into latent TB, this is again once the body has completely encapsulated all of the TB bacteria, it is moved into what we call the latent TB stage or the dormant TB stage. The disease can remain dormant for years. It can remain dormant for months, even a lifetime is what we're looking for when we have these patients that are TB positive. But what we want to do is we want to keep them in this latent or dormant phase. And this is, like I said, when we have the TB being fully isolated and encapsulated by that tubercle. These patients will not exhibit any symptoms. They won't feel sick. They're not even contagious during this time. So what we want to do is we want to make sure that we do everything possible to get them to this latent TB and keep them in this latent TB category when it comes to the different categories of TB. Now, when we do the PPD exam, when we look at the Manau test, they will still pop positive for TB. And they'll pop positive with the blood test, which is the QuantiFERON TB Gold test. So those two tests will still be positive, and you'll see some residual scarring in your chest x-ray. And so we'll see those things in our tests, but we'll talk about it a little bit more in the diagnostics phase, where we start to see it no longer showing quote unquote active. But at any moment, your dormant TB can become active again, And our biggest trigger for this is a depressed immune system. So that could be a change in living situations where you were living by yourself. Now you're in a nursing home, or you're in a homeless shelter, or you're in jail. Moving from not being a substance abuse user to IV drug use and or alcohol abuse. You could need an organ transplant and be on immunosuppressors and increase your risk for moving from latent into reactivation TB. So another name for reactivation TB is active TB, post-primary TB, reinfection TB, and secondary TB. So these are all different names that can come up when it comes to this phase or this category of reactivation. So the reoccurrence of TB can be months or years after the initial exposure. When we look at this, if we have uncontrolled TB, we can get further growth of those caseous granulomas, or those nutshell-like structures. And when we look at some of the symptoms that are associated with TB or this reactivation TB, some of the major symptoms with severe TB, we can have a low-grade fever. Patients can present extremely fatigued, night sweats. Go ahead and circle, highlight, underscore, star night sweats. Violent coughing episodes. This is most likely going to be bloody sputum. Go ahead and circle that, highlight that, underline bloody sputum. This is going to be bright red blood, frank red blood with the symptoms with severe TB. If it's not bloody, the patient can have a greenish sputum. Patients can present with chest pain, anorexia, weight loss. These patients are highly infectious at this point. They're highly infectious at this point. So 3 things that you need to underline, highlight, and circle are the night sweats, bloody sputum, and unexpected weight loss. Those are 3 key signals for you to be thinking and your antenna to be going off that this patient may have tuberculosis. In the event that those cavities that are formed, those granulomas that are formed, in the event that those rupture, this now allows all of that infectious material that's been encapsulated to spread throughout the entire lungs and the rest of the body. So this is something that we definitely do not want. That blood or that infection can impact the pleural space. It can impact the esophagus, the lymphatic system, and even the bloodstream. And once it goes to the bloodstream, we know that that's going everywhere. So that's incredibly dangerous. And that's where we start to get some of those other organs that are involved. Risk factors that move from latent TB over to reactive or active TB, like we talked about, immunosuppressed. Go ahead and circle the immunosuppressed. Organ transplant, cancer patients, HIV patients, patients that are malnourished, patients that are moved into institutional housing or overcrowded living conditions, jail, nursing homes, homeless shelters. All of those increase our risk for getting TB and moving into reactivation TB. So all of those, oh, balloons showed up. All of those are risk factors when it comes to either acquiring primary TB and reactivation TB, along with the alcohol and IV drug users.